here.
The respiratory system moves air through the nose, pharynx, larynx, trachea, and bronchus to the alveoli where the gas exchange between oxygen and carbon dioxide occurs. Nares are the openings to the nose. The nasal cavity is lined with cilia, mucous membranes, and blood capillaries. The air is filtered by cilia, moistened by mucous membranes, and warmed by the blood. Air moves into the pharynx or throat, the common passageway for food and air. Air continues on to the larynx. The epiglottis, a flap of tissue in front of the larynx, closes off the larynx when swallowing to prevent food from entering. The larynx or voice box contains the vocal folds. The trachea or windpipe connects the larynx to the bronchial tree. The cartilage rings of the trachea prevent the trachea from collapsing. Lungs are spongy tissue with alveoli and blood capillaries. Breathing occurs because of the expansion and contraction of the lungs. The bronchi carrying the air subdivide into smaller branches called bronchioles. At the end of each bronchiole are the alveolar sacs. The alveolar sacs are surrounded by blood capillaries and contain millions of single-layer alveoli cells where the gas exchange takes place. Oxygenated air goes from the nose to the pharynx, larynx, trachea, bronchus, and alveoli. By the process of diffusion, oxygen in the air moves from the alveoli to the capillaries. Carbon dioxide moves from the capillaries to the alveoli and is exhaled. This process is called respiration.
All right, so where does the gas exchange occur? Who can tell me, where does the gas exchange occur?
The stomach?
What? We're in the respiratory system, Norma. Gas exchange does not occur in your stomach. It happens in your lungs. We're on chapter 6. So, did you watch the video I just played?
Yes, pero tengo a mi daughter y al niño de Janie aquí, so I can't really hear it.
Okay. So, the respiratory system, as the video demonstrated, it has different parts. It has your nose or your sinuses right here. The main job of the sinuses is here to obviously clean out the air, filter some of the larger molecules that or dust, whatever goes into your nose, and trap it, with the hairs that we have inside, and then we have smaller ones that are deeper in there. But it also is responsible to warm the air. And we cannot breathe dry air. You notice that some people that start breathing dry air right away, they start to get allergies and they start coughing and they develop all these symptoms because they're very sensitive to the changes. Any allergy, guys, please remember this. Any allergy is a hypersensitivity. It means that you're too sensitive to something, whatever it may be. It could be air, it could be dust, it could be strong odors, it could be a food. So if your body is very sensitive to that means you have a hypersensitivity or an allergy to that. All right, and this is what happens a lot with the air. I know that sometimes when there's new winds that come from the east and they come in through the ocean through the south and they make their way up here, my tonsils feel like I'm gonna get sick, right? My throat starts to bother me and all that, and then it goes away. Okay, and I know this when it gets really windy, especially if there's a lot of dust that comes in. Remember, all the winds from all over the world, they go up and down, back and forth, and that's how we end up with coronavirus here and other viruses, infections. So your airway has to make sure that it traps all that and cleans it out and warms up the air. And then it makes its way down or back into your airway, into your trachea. Your trachea is also lined with mucous membranes that are very sensitive to a lot of things, and if they're sensitive to something, they're going to start to produce a lot of mucus. Okay, a lot of mucus. Your esophagus is supported by muscle, so it stays erect, right? But that muscle also produces mucus. So anything that that alters that is going to create an allergy. All right, so the gas exchange occurs in your lungs, but specifically where in your lungs? It's called the alveoli. So if you go back and watch that video, you can understand what happens. It's very important that you understand the gas exchange. Okay, so when we breathe in air, we're breathing in air, and in the air we have oxygen, we have CO2, we have a lot of different other gases here in the air. But your lungs only take up the oxygen. The oxygen is then put into your arteries, okay, taken back to the heart. So the heart and the lungs are very well connected, very closely connected. Any alterations in your lungs or the air, the gas exchange, will affect the heart, and vice versa. Any problems with the heart, your lungs are going to feel the difference right away. So they're very, very connected. Okay, so all these little changes we have to make sure that we look out for those changes. And I'll go more into that in a little bit. So please understand the breathing cycle, right? Inspiration and expiration, so that you're familiar, at least, with the gas exchange, with the anatomy of the heart. You have your trachea, and then you have two bronchus, which are the main bronchus, the left and the right. And then we have bronchi, which are the smaller branches of the respiratory system. They're passages that air goes in through there. And then lastly, you have your alveoli, these little pockets where all the gas exchange, all your capillaries are there. This is where the gas exchange happens. Just like in our body, we have capillaries. We also have capillaries inside your lungs, specifically in your alveoli. So again, please make sure that you understand that we breathe in oxygen and we exhale carbon dioxide, and it's a delicate balance. Okay, it's a very delicate balance. Any changes in that can actually make you feel dizzy, lightheaded, or even pass out, right? So when we're short of breath, we're not meeting enough oxygen needs. That means we need more oxygen. So some people that have conditions, they have to get supplemental oxygen, and we'll talk more about that in just a minute. So what can affect your airway system? Well, number one, of course, are infections, right? If you get an infection, it's going in your respiratory system, just like COVID, okay? It affects your respiratory system because it causes inflammation, secretions, and a lot of problems. But that's not as common as other problems like pneumonias, which are, again, we are in flu season. So a lot of people start to develop the flu, right? Influenza, signs and symptoms of the flu. We have people that develop pneumonia or infections of the lung for many reasons. So other problems that can also cause respiratory conditions are neurologic problems. I know that with Parkinson's disease, as the disease progresses, the person is unable to use that muscle that stimulates your diaphragm. The diaphragm is located around your lungs, okay? It kind of encapsulates, it surrounds it. So when you breathe in, that diaphragm stretches and helps your lungs expand and then come back to normal. So that diaphragm has to make sure that it works really, really well. So people with Parkinson's start to lose function of their motor nerves, right? The nerves that stimulate other parts of your body, such as your arms and legs and all that. But more importantly, your diaphragm, right? Your diaphragm is a muscle. It's stimulated by nerves. So with Parkinson's, we see some of these problems, changes in breathing pattern and so on. They get tired very easily and so on. People with a quadriplegia will have trouble with breathing because they're not unable to control that diaphragm at all. Okay, remember that the breathing is voluntary, but it's also involuntary. Okay, we breathe. If your body feels that it needs to breathe, it's going to take a deep breath. Okay, it's not you, it's your body doing it for you. So quadriplegia may be another one. Disorders that cause the alveoli to fill with fluid, such as pneumonia, which is an infection. There's disorders that cause the alveoli to collapse. Okay, the alveoli, the little pockets where the gas exchange happens, they can collapse, okay, making it very difficult for you to exchange gas, makes you short of breath and all that. We call that atelectasis, or collapsing of the alveoli, okay? And we can see this, so the doctor can see this in an x-ray. If you look at a normal x-ray, your lungs actually look black, okay? It looks black. Black is the air. Is air, which is perfectly fine. Sometimes you'll see black in one lung and you'll see partial black on one side and then just white, and this side, that's a problem. Okay, so we have to see, make sure the lungs are completely black. And that's how we know that the lungs are working normally. People that have a history of smoking, they develop emphysema. Okay, that means that the alveoli, or the circulation to the alveoli was destroyed by the consistent smoking. The nicotine destroyed the the capillaries there in the alveoli. So therefore, they cannot exchange gases anymore. So this is a problem. There's disorders that prevent blood from entering the lungs to receive oxygen, such like as pulmonary embolisms. Pulmonary embolisms are a very, very serious condition. People can die from that almost instantly. So again, that could be another problem. And there's other many other reasons that can be caused by trauma, car accidents, falls, and so on. Your lungs can be damaged, and they can stop you or keep you from breathing normally. So there's a lot of causes that can affect your breathing pattern. Asthma is probably more commonly, right? Asthma can be chronic. It's a chronic condition that closes your airway. You're unable to breathe, so it makes it very difficult for you to get enough oxygen into your lungs because your airway is already closed. Okay, so that's another one. All right, now other disorders that might affect your breathing, of course, are anemia. If you're anemic, that means that your hemoglobin levels are too low. Hemoglobin is actually the one that carries oxygen, right? Oxygen has to be delivered to all of your body. If not, your body will notice the differences, okay? So if you're anemic, you may feel more tired, lack of energy. Why? Because again, you're lacking oxygen in your muscles. You may get tired much more easily than you normally would. Heart failure, your heart is unable to function normally, like strongly like it used to. So we have a lot of elderly residents that have heart failure, and with this problem, their heart is unable to meet the demands of the body. So the body doesn't get enough oxygen, right, delivered because of the lack of blood flow. So again, they feel the symptoms of fatigue and lack of energy and so on. Carbon monoxide poisoning, it's not happen often, but of course, your body you can actually die, right, from the lack of oxygen. If we're exposed to carbon monoxide, which is odorless, okay, we can't really detect it, but if you smell, enough, take in enough carbon monoxide, you can obviously die. How do we know when people are getting enough oxygen or they're not getting enough oxygen? Well, we can always look at the patient, right? We look at the patient first. We look at the patient and we see their color, right? More commonly, we can look at the insides of the lips, right? Not this part. We see the inside. And usually if we look at someone's normal, okay, you look at the inside, it's kind of pink or even red. That's very good. Now, if you notice that it's getting kind of bluish, it's discolored, it's not pink, then the person is lacking oxygen. Okay, that's one of the ways. Another way you can look at them is by looking at their nail beds. Okay, the nail beds are like the windows to the inside of your body, right? So they're here for a reason. Okay, polish is not always a good thing. So when we have patients that have nail polish, we always try to remove at least one of them so that we can see their nail beds. If you look at your own nail beds, you'll notice that these are pink, or they should be pink, right? If they're pale, you might be anemic. So if the ends of the nail are getting a little bluish, they look a little discolored, that means that the person is not getting enough oxygen. So that's another sign. And of course, they get short of breath, they get tired very easily, and so on. So it's important that we monitor the patients, not just with machines or with equipment, but look at the patients. We always look at the patients. And if you can be that kind of a healthcare team member that can be very observant, notice these changes that are very subtle, okay, you can actually help someone out very, very, very good. Let me see what else. So we use pulse oximetry. Pulse oximetry is a way of measuring the oxygen in the bloodstream as a percentage. So we have these devices that we can put on the fingers, okay? It clips on here and it has a little red light. It's an infrared light, and it measures the amount of hemoglobin that is in your blood, right? So if you have a lot of hemoglobin, that means you're going to have a high amount of oxygen being carried around by your hemoglobin. And that's what it does. But we cannot always rely on these machines because, number one, if a person has um, nail polish, it's not going to work. Okay, it's not going to work with dark nail polishes unless it's just a clear polish. Number two, more common, if a person has cold hands, it's not going to be accurate. It's not going to be accurate. Okay, it's going to give you an incorrect reading. So do not report incorrect readings. So you look at the patient and look at the nail beds, look at the lips. If the reading on the pulse oximetry is low and you see the signs of, hypoxia is low oxygen level, then you can tell me, okay, yes, the person is suffering from, low oxygen levels. Another sign that you may see is confusion. Sometimes patients will get more confused, right? Now we know that some elderly patients suffer from confusion. No, they're normally confused, but there may be subtle changes that you can observe on patients. I just had a resident that was sent to the hospital because he had an alteration in his breathing. He was breathing really fast and then he would stop, fast and then he would stop. And he would tell me that he wasn't feeling well. So the patient had to be, sent to the hospital, and he did have a problem in his lungs, an unusual problem that we couldn't have suspected. But he's still there. He's getting care. He's doing well. But again, sometimes we rely on machines too much. Okay, machines were telling us that everything was normal, except the signs that we were looking at were not normal. So we have to act. So again, any dark fingernail polish is not going to work. Use the same arm to measure the blood pressure. If you put the blood pressure cuff on and then you put the pulse oximetry on here, it's not going to work, right? Because you're cutting off circulation. So you have to wait until it's done or use another hand. Poor circulation, people that have poor blood flow, especially to the hands, like I said, people with cold hands, it's going to give you an incorrect reading. So don't just go by what the little device gives you, where it tells you, look at the patient. Are they doing well or are they not doing too well? Okay, another way we can tell how their respiratory system is doing is by performing arterial blood gases. And we talked about this in phlebotomy class. Arterial blood gases, it's a study, an exam of the amount of oxygen, carbon dioxide. There's a bunch of different labs that are done in arterial blood gases, or ABGs. And these are collected usually by respiratory therapists. They're the ones that collect it from one of the radial arteries or the ulnar artery. And it tells you a lot about the condition of the patient, including their pH levels, their partial hydrogen levels. Very, very, very useful information when a person, especially those that have respiratory conditions like emphysema or any kind of COPD or pneumonias, whatever the case may be. Our ABGs are very useful too. Again, they're collected by the respiratory therapists. What disorder affects the ability to carry oxygen to the blood? The ability to carry oxygen, that's going to be your anemia. Anemia, if you have low hemoglobin levels, you're not going to be able to carry enough oxygen, thus causing you to be short of breath. Okay, so that is one of the problems. Pulse oximetry, here we have an image of pulse oximetry on an adult and then on a little infant or baby. Can y'all see the PowerPoint? All right. No, here it is. So which is a normal pulse oximetry reading? A pulse oximetry reading usually is going to be 90, well, here it says 95 or better, but 92, 90% is still acceptable. Usually 92% or higher is considered normal, but 95 is almost like somebody that doesn't have problems. But on patients that we know that already have a respiratory condition, 90% is acceptable because we know that the person cannot produce 95. So 90, 92% is also acceptable. Again, depends on the condition of the patient. So our ABGs, again, very, very good study, very accurate, okay? And it requires, of course, the therapist to collect the specimen, but a very useful information. A lot of times they're ordered stat. So ABGs need to be collected stat, preferably by the respiratory therapist or an advanced phlebotomist. And remember, the ABGs required to be put in ice. They need to be chilled so that all the electrolytes and all the gases stay intact. Now, patients will require oxygen at some point, right, while they're in the hospital. There's many ways of receiving oxygen. The most common one is obviously through a nasal cannula. The nasal cannula is those little two prongs that go in through your nose, okay? That can deliver up to 4 or 5 liters of oxygen at once. So the amount of oxygen is determined by your ABGs, okay? If the doctor sees that your oxygen levels are pretty low, like in the 80s, they may give you 3 or 4 liters and to get them up there, as long as your oxygen saturations are above 90%. Why do we need your saturations above 90%? Because if not, your organs are going to suffer from low oxygen levels, especially your heart, very sensitive to the levels of oxygen. If it senses that it's lacking oxygen, it's going to start beating faster, okay? And that your heart rate is going to go up. Your lungs are going to be working faster as well. So it's going to create some problems. So that's why we have to make sure that there is that balance. So nasal cannula is the most common way that you're going to see oxygen being delivered. And then you have your simple mask. Here's a picture of your nasal cannula. Make sure that they don't use any kind of petroleum lubrication in here. Make sure that we protect here around the ears, especially if the patients cannot speak. Some patients can deliver or develop ulcers in the back of the ears because this part is cartilage. It's very easy to develop ulcerations. When a person does have oxygen, make sure that you do not change the setting. The machine is beeping or is malfunctioning. If the patient complains that they're not getting air, it may be because the tubing is kinked or maybe disconnected, but do not change the settings on the oxygen because it's prescribed at a certain level and it shouldn't be tampered with because the patient will develop symptoms of low oxygen. You have, of course, your simple face mask. This mask can deliver a little bit more oxygen than the previous one. So you can have up to 50% oxygen, maybe 7 liters or sometimes 8 liters of oxygen. In this case, the person will require high oxygen flow. The machines, the ones that you see, those are oxygen concentrators that clean air, usually can only deliver about 5. Sometimes they can go up to 8, but they may not be able to deliver more than 8 liters of oxygen per minute. So this is a simple mask, and then you have your non-rebreathing mask. This non-rebreathing mask, when I see someone or you see someone with a non-rebreathing mask, it's not a good sign, right? It means that they're having a lot of trouble breathing. They're not getting any oxygen exchange in their lungs. So therefore, this allows the patient to be able to get a balance between carbon dioxide and oxygen at the same time. So oxygen flows in through here, right? And then when they exhale, they actually take in back their CO2, their carbon dioxide. So this is not a good sign. This is probably someone that's maybe in a hospice situation where they're maybe on their last days and you see them that having trouble breathing. They may be giving a non-rebreather mask, okay? So they can, the oxygen flow also goes into the bag and they can receive 100% oxygen, right? So we started with 2-3 liters, which is about 25%. Then these give you 50%, and then these bags can give you up to 100% oxygen. So again, this is not a good sign. And lastly, we see masks like these, okay? This is called a Cpap, a continuous positive air pressure. It's a fancy name for saying that it blows in there air into your airway system and it keeps your alveoli, your epiglottis open, okay? Now, why would you ever need something like this? This is actually more common than you think. It's prescribed for a condition called sleep apnea. When a person stops breathing for a certain amount of time, it could be seconds, it could be a minute, which is a lot because your body's going without oxygen for a whole minute. It's a big deal. Well, if you're all night, having to stop breathing without oxygen, you might have 5-10 minutes in lack of oxygen, and you may develop complications over a period of time. Okay, there's a lot of complications that can happen. People that snore also have a problem with breathing. So if they snore a lot, they may feel that in the morning they're not really rested, that they're always tired. They may be falling asleep during the day because they didn't get a good night rest. So a CPAP is one of the ways to ensure that they have adequate air or oxygen exchange in the lungs. Okay, these are always used during the night, preferably to sleep. Okay, now most commonly you see it in patients that have extra padding around here, around the neck area. Then this extra fat here actually opens your airway when you're sleeping. So if it's open, you're going to be snoring, and if you're snoring, then you're not getting oxygen into your lungs. So a CPAP would be indicated in this kind of situation. Most commonly, and we find it in obese people that have sleep apnea. So where the following statement is true: a person with sleep apnea may also use a CPAP. Yes, of course it's true. And sometimes the CPAP can be used with or without oxygen. Okay, but these are little machines that they can get to help them breathe better. Give me 1 second. Yes. So as I was saying, sleep apnea is a serious condition, and it needs to be treated. And a lot of times it goes untreated, and people develop serious complications over a prolonged period of time because of this. So the snoring is not always good. There's a lot of treatments for snoring. So if you have someone in the family that snores a lot, they should really get some kind of treatment, and they're going to feel the difference. Believe me. People that use a CPAP, they're supposed to use it. Many times they don't want to use it, but when they do use it, they do report getting a better sleep, and they feel more rested. So oxygen dose is determined, again, prescribed by the physician. It's delivered in liters per minute. Okay, so again, make sure that that we don't change the settings on the oxygen that's been prescribed. We're gonna have to be providing good oral care if they're on oxygen, because all that dry air that comes in through the nose comes back into the mouth and dries up the mouth. So they're gonna need some kind of oral care, especially if the patients are unconscious or in a coma. The oxygen concentrators require a little bottle that has water. The oxygen is connected into the bottle, and it picks up, as the air goes into the bottle, picks up humidity, and it goes out into the patient. So that way the nasal airways do not get dried up, because otherwise they may start bleeding from too much dryness in the nose. Remember to check the persons again for pressure sores around the ears or here in the bridge of the nose. If they have one of those masks, the mask that goes here, they may put pressure here and it causes them an ulcer. Again, report any nosebleeds because of excessive dryness in the air. Maintaining an open airway. Patients that have a trachea, okay, an artificial opening here, either because they couldn't breathe on their own anymore, they ended up getting a tracheostomy here, will require some kind of suctioning. Suctioning the airway requires that we go in there and remove the phlegm or the sputum that has been produced. Some patients produce a lot sputum, and some patients do not produce a lot. So we have to make sure that we keep an eye on them. Whenever they start coughing up, okay, we have to go in there. This requires sterile technique. There is a kit, okay, a suctioning kit that I'll show you next time we meet on Wednesday. Remember, we're coming here Wednesday. You can suction the airway using sterile technique. You have to put on gloves in a sterile manner, okay, and then use the equipment and in a sterile manner to be able to suction the secretions out. If we don't suction the secretions or take them out, they can develop what we call mucus plug. Okay, all that mucus becomes very thick and dry, and it can plug the airway. So it's really important that we suction them on a regular basis. Now, you may or may not be able to perform this on patients, but if it's an emergency, you should be able to perform that suction in the airway. Now, we can do it either orally sometimes, or sometimes through the nose. We have to put the catheter in all the way to the nose, all the way to the back of the airway. If they have an endotracheal tube, they're intubated, or they have a tracheostomy, which is probably the most common way, you have to be able to provide it. Now, how do we perform suction on a person? Well, sometimes we can go in there, and I'll demonstrate it for you next time we meet on how to suction the airway. We suction, but we don't suction like continuously all the time. We don't want to take out the oxygen that is in the airway by the suctioning. So we have to provide it in a certain way where you don't produce hypoxemia or low oxygen levels. So I'll show you how to do that when we meet here in person. The person may need suctioning if they're not able to cough out the secretions, if they're having trouble breathing, if you see them changing color, turning blue on the lips or the nail beds, okay? The pulse oximetry reading is getting a little bit low. We may have to go in there and suction the airway. It's very, very critical that we do that. Or we tell the nurse, that the person is having trouble breathing and they have a tracheostomy or, whatever it is, make sure that we report that. So there's nasopharyngeal and oropharyngeal airways. Nasopharyngeals, it's one of the ways that we introduce or perform suctioning, rather, through the nose and through the back of the throat. Now, the person must be able to cough up the secretions so that we can suction them, because we only go up to here. Okay, from there, the person has to bring them up, and we're able to suction them that way. If not, sometimes we can introduce to the oropharyngeal, which is the oral, and the pharyngeal, which is the pharynx or the upper part of your airway. The patient also has to be able to bring up the secretions so that we can suction them out. We'll be learning how to perform tracheostomy care, which is something that one of the procedures is done very commonly on patients that have a tracheostomy. Remember, a tracheostomy is an artificial opening in your trachea. So once there's an opening here, it's open for anything, for infections, for anything that can go in there. So we have to make sure that we perform the care adequately so that we can prevent any complications, including infection around the stoma or infections going into the airway. So you'll be learning how to perform tracheostomy care next time we meet here. So again, this may be or may not be beyond your scope of practice, depending if the nurses know that you're able and capable of doing suctioning, performing tracheostomy care. This can be relayed to you or be within your scope of practice. Again, in acute care settings, when there's one nurse and there's 5 patients, that are very highly sick or very acutely sick, we have to perform the care, and we need someone that can help us. In this case, it would be a patient care technician that we delegate these things to. Like, again, we said, if I know that you're good and that you can do the job right, I will, allow you to perform it. So, but if I know that you can't or that you don't have experience, I will not delegate anything that is not, that within your abilities. So we'll be performing suction and tracheostomy here, and then providing tracheostomy care next time we meet. Patients that have a respiratory failure, meaning that their lungs are no longer functioning or providing adequate oxygenation to the body, will have to be intubated and then placed on mechanical ventilation. Just like a lot of these patients that were developed COVID coronavirus, develop a lot of inflammation to the alveoli, to the lungs, and they were unable to exchange gases. They had to be placed on a ventilator so that the machine can actually breathe for them. Okay, the machine would push in air and they would deflate the lung. It's actually doing whatever your body's doing right now to help you stay alive. That's what the machine does. It blows in the air and then it deflates it. Okay, so it tries to mimic the same functions that we do. You know, about 18 to 20 respirations per minute. You know, it gives you enough air to inflate your lungs depending on your body size, and then deflates it, but leaves it partially inflated, and so on. So these machines are very useful when a person is very acutely sick, either because of like coronavirus or some other disease or infection, or even an accident. If they're unable to breathe on their own, the machine will do this for them. This can be done obviously for a temporary purposes. It's not meant to be permanent for adults. There are little babies though that are on a ventilator, and they are on there for a very, very long time until one day they're able to be removed, or we call it weaned off the machine. Later, they're slowly, gradually removing the amount of air that the machine pushes in so that the babies are able to breathe on their own, if possible. So mechanical ventilation, again, is a very useful medical technique to help pretty much keep people alive. Another respiratory problem or condition is called hemothorax. Hemo means blood and thorax means the chest. Sometimes people will develop blood in their lung because of trauma or infections or cancers. So if a person develops blood or gets blood inside their lung, obviously that's going to affect the way the gas exchanges. So my resident that I had the other day that was mentioned earlier, he developed a partial hemothorax. We still don't know why he developed that partial hemothorax. It wasn't from a fall because he hadn't fallen. So hopefully not. He's developed any malignancies or cancers, but there's got to be an explanation why he developed this hemothorax. Okay, so chest tubes. Chest tubes are tubes that are inserted into the lung cavity. So your lung is like this, and it's surrounded, okay, by a sac. Okay, and in between the lung and the sac is called the pleural cavity. So if you're in an accident and you have some kind of, we call it blunt trauma, meaning like somebody punched you or something hit you on the side of your lungs, or or your body was just shaken too much, right? You can develop fluid going into this pleural space. Okay, if there's a lot of fluid in the space, it's going to keep your lung from expanding. Okay, and it's going to give you trouble breathing. Okay, so anything that affects, or any fluid or whatever goes, is called air or blood, right? A pneumothorax or hemothorax, it fills the space. It doesn't let your lungs expand. It's going to give you trouble breathing. So what the doctors, the way they treat you is that they'll place a catheter, just kind of like the IV catheters, but in case the catheter is going to go in that space, in the pleural space, and it's going to drain some of that air. Okay, it's going to drain it out. Okay, or if there's any fluid, pus, blood, or whatever's in there, it's going to drain it out. Okay, into what we call a chest tube kit. Okay, or it's kind of like you see a picture in the book on page 125. It's filled with water. Okay, what we do is that it creates a water seal. So air or fluid comes in to the container, into the chamber, and then it bubbles out. Okay, air comes in and then it bubbles out. into the atmosphere, into, outside. So the idea is to allow the lung to recover by removing some of that air that is caught in between that space, and that way you can start breathing better. Okay. Again, this treatment is used for people that have a pneumo means air, thorax, or air in the pleural space, or a hemothorax. Sometimes there's blood and air in that pleural space, and it's removed by inserting a little chest tube, a catheter into that pleural space, drained into a large container that has a water seal, okay, to prevent from going back up into the lung. This would cause the lung to deflate once again. So it's a very useful tool. So whenever you see a chamber, right, a chest tube kit or drainage system, it's because a person has air or blood inside the lung. One important thing to remember is that these drainage systems have to be below the body, right, below the lungs, and it cannot be turned on its side. It has to be kept up vertical at all times. All right, there's a lot of things that you might see in an acute care setting, such as in a hospital, in the emergency room, a lot of respiratory problems that you'll see. And after you see, a few here and there, you'll notice that a lot of them are pretty much the same. They're very easy to manage after you've learned, getting some experience from exposure to these conditions. So we covered in this section, chapter 6, respiratory care skills. So remember, more importantly, to observe the patients for signs of low oxygen levels, such as in the oral mucosa, the lip, the inside of the lips, your nail beds. Make sure that they're not purple, okay? Make sure that you report any low pulse oximetry readings below 92% have to be reported. Make sure that you're performing the reading accurately, okay? Make sure that the person doesn't have, low circulation, cold hands, or nail polish or things like that. So that is completely within your scope of practice. You might again be trained to be performing suctioning on patients. Some families learn it because they needed to, they need to perform it to the patients. All right, give me 1 second.